Welcome to the Johns Hopkins Medicine online webinar series. Today, our reproductive endocrinology and infertility specialists, Dr. Katie Cameron and Dr. Chantel Cross, will be speaking about understanding fertility and when it becomes infertility. Before we get started, we'd like to provide some user tips so that you are comfortable using this platform. The first 30 minutes of our program will include an informative presentation by our presenters. The last 30 minutes will be dedicated to our live Q&A session. Please note this program is being recorded. To submit a question, please type your question into the Q&A box and click send. Your questions will be seen by others watching this presentation, so please note if you do not want your name attached to your question, please check send anonymously. Also, your email address will not be shared with any third parties. We will do our best to answer all questions we receive during the Q&A session. Alternatively, you can email us questions and feedback to hopkinsseminars@jhmi.edu. At the end of the webinar, we would greatly appreciate receiving your feedback and ask that you complete our survey. A pop-up window will appear at the end of our program for you to complete the survey. And now I would like to welcome Dr. Katie Cameron and Dr. Chantel Cross to begin our presentation.
Great, thank you so much. My name is Dr. Katie Cameron, and I'm here with my partner, Dr. Chantel Cross. And we both practice at the Johns Hopkins Fertility Center. And we're excited to speak to you today about understanding fertility and when to seek care for infertility. Just a quick disclaimer before we start, the sort of language that we use in this presentation, just for sort of ease, is going to be assuming heterosexual couples where the partner, one male, one female, but obviously we support kind of family building in all shapes and sizes and recognize that that doesn't fit everybody's situation. So first, before we launch into fertility at all, just kind of taking a step back and talking about some things that you may want to think about even before trying to get pregnant. Most likely all of you are listening in on this webinar because you're considering pregnancy. And so before we jump into that, just a few things to think about to try to optimize your health prior to starting to conceive a pregnancy. First is to just make sure that you're taking a prenatal vitamin or a multivitamin that contains folic acid. That's important for development of a healthy pregnancy. We recommend avoiding alcohol and smoking if you are trying to conceive. We think that some caffeine in moderation is all right and has not been strongly shown to be associated with risk of infertility or risk of miscarriage, but we would prefer that you limit that to 1 to 2 cups per day. We recommend maintaining a healthy lifestyle, and this includes just a nutritious diet and some regular exercise. People often will ask us about kind of what's the best fertility diet. There is no sort of magic diet solution, but just making sure that you're maintaining a balanced lifestyle. It's important if you're taking medications for chronic medical issues that you review those medications with your physician prior if you're considering pregnancy. Oftentimes for any given condition, there may be medications that are more preferred in women who are pregnant. And so your physician may want to make some changes to make sure that your medication list is optimized prior to becoming pregnant. We also recommend blood testing before you become pregnant for your blood type to check to see if you have immunity to rubella and to check to see if you have immunity to varicella. These are viruses that could be detrimental to the pregnancy if you were to be infected during pregnancy. And it's also not safe for you to get the vaccine to prevent those viruses while you're pregnant. So checking that blood work ahead of time before you become pregnant provides then an opportunity for you to receive the immunization if you don't already have immunity. Genetic carrier screening is something that some couples will choose to consider. So this basically screens to see if you and your partner are at higher risk of conceiving a child with specific genetic diseases. This is sort of just a general screening panel that can be offered through your primary care physician. This is really kind of a personal choice, but we do know that 80% of the time that a child is born with a serious genetic defect, there was no family history. And so genetic screening ahead of trying to become pregnant can sometimes help to identify if you and your partner are at higher risk. Um, and then finally, nobody is traveling as frequently right now in the time of COVID, and we do recommend avoiding COVID exposures if possible. We still can't forget about Zika. It is still prevalent, and so we do recommend avoiding travel to Zika-prone areas as well if you're interested in becoming pregnant. Just to kind of head off some questions that we think will most likely get asked at the end, we just wanted to share with you the statement that we're providing to all of our patients at Johns Hopkins Fertility Center regarding the COVID-19 vaccination in women who are considering pregnancy. So this is a long statement, but the important thing to note is that this vaccine is not composed of live virus, and so then therefore we don't think that there is an association with increased risk of infertility, of pregnancy loss, or other pregnancy complications from the vaccine. And so therefore we do recommend that any patient who is planning to conceive, if they're eligible for the vaccine and interested in getting the vaccine, that they go ahead and get it. There's no kind of amount of time that you need to delay trying for a pregnancy after receiving the vaccine. And then also importantly, if you receive depending on what type of vaccine you get, if it's a 2-dose formulation, if you receive your first and you become pregnant in the interim, we recommend still then getting that second dose at the scheduled time.
All right, so good morning, everybody. So I have heard or read headlines in fertility in the world on the decline and in the United States it's on the decline. Well, that is true. When you look at data for the past, over the past decade from 2007 to 2017, the number of live births has decreased steadily over that time frame. And we'll kind of get into why this is occurring. Can you advance to the next slide? We similarly look at age. We know that women are delaying childbearing. And so we look at the age at first birth of moms who are conceiving. That has also increased steadily since 2007 in all communities, rural communities, small, medium communities, as well as large metropolitan counties. This is data that's published by the Centers for Disease Control and Prevention. You can go to the next slide. So what we're finding out is that patients are choosing to delay childbearing, and this is driven by many factors, including later age at first marriage, increased levels of education and pursuing higher levels of education, which can lead to delayed childbearing. There's an increased percentage of people who are working outside of the home, and there have been, of course, higher divorce rates and higher rates of second marriages or second relationships where children are then wanted in those second relationships. You can go ahead and advance to the next slide. So what is the cost of delaying childbearing? Well, unfortunately, fertility for females does decline with age. And the female reproductive tract specifically ages to the point of failure well before other major organ systems, and the peak efficiency for fertility for females occurs in their 20s. And as you can imagine, most patients who are pursuing higher levels of education, et cetera, are not trying to get pregnant in their 20s, and it's not until their 30s and sometimes even beyond that they're starting to consider conceiving. And unfortunately, that's the time frame when our fertility is not the most optimal. The decline in fertility with age is thought to be due to a variety of factors, but is most driven by a decline in the number of eggs. Females are born with a set number of eggs, and that number of eggs declines over time. And unfortunately, there isn't any type of intervention medically or lifestyle-wise that can slow or stop that decline. It's just something that happens with time. And so as your number of eggs declines, it can become harder to get pregnant. Also, the quality of the eggs that we have also declines with time, and this can lead to delays in getting pregnant, and in some patients can lead to increased likelihood of miscarriages. The third reason is that the ovaries, which are obviously important for releasing eggs, but also producing hormones that support the growth of the egg, that hormone function within the ovary also declines with time. So it's these variety of factors that has led to the declining birth rates that we're seeing nationwide. You can advance to the next slide.
So with this in mind, kind of one of the first and most important take-home messages from this webinar is when to seek help if you're having difficulty conceiving. And so for most couples, this is if you are less than the age of 35, we recommend seeking assistance from a fertility specialist. If you have had 12 months of attempts without successfully achieving a pregnancy, because of this age-related fertility decline that Dr. Cross mentioned, we do recommend seeking help in a more expedited fashion if you're 35 years or older. If you fall into that age group, then we do recommend touching base with a fertility specialist if you have not been successful at conceiving after 6 months. Just to kind of normalize some of this data, though, I think it's kind of really important to have in mind a sense of kind of what is the per month success rate of sort of anybody trying to conceive. If you're listening to this webinar, most likely you're a planner, and it can be very challenging sometimes, when we make a plan to get pregnant and then it doesn't immediately happen. It can feel very frustrating and very disappointing. But to kind of normalize that, I think it's important to know that in the general population, the per month chance of a successful pregnancy is actually only 25% for any given couple. So even kind of when everything's, working properly, when there are no issues, the likelihood that a pregnancy will happen in any given month is actually only 1 in 4. So I think that's important to kind of keep in mind, especially like I said, when kind of, you've made a plan and it seems like everyone around you is getting pregnant, all your friends are getting pregnant. It's kind of, I think, just important to have that statistic in mind to not feel so frustrated. After about 6 months of trying, about 60% of couples that have been trying for 6 months at that point will have achieved a pregnancy. And by a year, about 85% of couples will have achieved a pregnancy. And so at that point, then if there has not been success, then that is when the official diagnosis of infertility is given. So technically, infertility is no pregnancy after 12 months of attempting to conceive. And so this will be in the literature anywhere from 11 to 15% of couples will experience infertility. Again, just to review when to seek help. If you're less than 35, those 12 months of trying, then it's time to come and see us. If you're older than 35, though, we would like to see you sooner after 6 months of conceiving. The one exception to this is that if you are somebody who is not having regular periods. And so what regular periods means is that you're having monthly periods. They're pretty reliable, generally within 2 to 3 days of each other. So for instance, if your periods, if you are keeping track of them, are typically every 27, 28, 29 days, that's completely normal. Normal period length of time, essentially from the first day of bleeding in 1 month to the first day of bleeding in the next. Anything between 25 and 35 days is normal, but they should be sort of consistent within 2 to 3 days. So if you're a 32-day length, 33 days, 34 days, all of that is totally normal. If you're somebody who's going 25, 35, 25, that's a little bit of a gray zone, and that may be something that you want to talk to your physician about. If you're not getting periods at all, or if you're only getting periods here and there, skipping months, then that's a situation where actually you do want to see a fertility specialist sooner than those recommended guidelines, because most likely your ovaries are not ovulating, which is a sort of necessary requisite in order to achieve a pregnancy.
So I'll talk a little about timing. So this is something I talk to all of my patients about, is trying to figure out when your fertile window is. And so the first thing to do when you're trying to conceive is, as a take-home message, is regular intercourse is never a bad idea. Because if you're having periods, whether or not your periods are every 26 days or every 32 days, if you're having sex regularly, then you should be able to have sex during that fertile window. But if you want to do a little bit of a deeper dive into figuring out, well, when should you maximize your attempts, it's really important that you start tracking your cycles. And with technology, there are many different ways that you can do this. The easiest would be an application on your phone, and there are a variety of them. You look at and track your cycles from the first day of bleeding to your next day of bleeding and figure out what that length of time is. And if you have, for example, 28-day cycles, then it usually takes about 2 weeks from the start of your period to release the egg. So that's 2 weeks to kind of grow the egg. And then from the time frame of ovulation to your period is typically another 2 weeks. That's the classical 28-day cycle. So if you look at your application when you've been tracking your cycles and you say, okay, well, my period happened on this date. If you track back 2 weeks from that date, that is usually the time when you've ovulated. It's really important to have sex before ovulation because that is what's going to maximize your chances. Sperm can live within the female reproductive tract for up to 5 days. So sex before ovulation is better than sex afterwards because the egg, once it's released, is only around for about 24 hours. So it's really important to have sex at least every other day leading up to your time of ovulation. There are things that can assist in making this timing more precise, something called ovulation predictor kits, which are urinary kits that you can purchase at your local drugstore or on Amazon, where you can start tracking your urine to see if they're detecting a hormone that we know rises usually within 24 hours of ovulation. And so that's something you can add to your routine if you want to. But as I said before, if you're having regular periods, then having sex every other day throughout the month or throughout that first 2 weeks of your cycle should cover most of your bases. Go ahead.
All right, so then moving on. So let's say kind of you're approaching the 12-month mark and you're wondering, well, what would happen, if I did see a fertility specialist, kind of where would we start in terms of evaluation? Please forgive me for creating this figure. We didn't have permissions for an official figure. So this is a handmade figure just to kind of help us sort of take a step back and review kind of, what are the things that we know need to be in place in order for a couple to achieve a successful pregnancy. So our kind of schematic of evaluation, first thing we think about is the ovaries. We've already touched on a couple of these things, but we'll investigate kind of how many eggs are remaining in the ovaries. What is the function of the ovaries? Are the ovaries effectively ovulating? And kind of what is the hormonal communication that's happening from the brain to the ovaries? Are the ovaries functioning properly? The other thing that we think about is what's going on with the fallopian tubes, because it's actually the job of the fallopian tubes to pick up the egg that is released from the ovary each month to bring it to meet up with the sperm and then bring that resulting embryo down into the uterus. And so we will investigate, are the fallopian tubes open and functional, or are there potentially blockages in the fallopian tubes that could be preventing that successful pregnancy? The third thing that we think about is what's going on inside of the uterus. Is the inside of the uterine cavity a place where an embryo would want to implant and grow, or is there something potentially going on inside of the uterus that's preventing that? Sometimes these can be things like fibroids, which are just sort of balls of muscle that are located inside the uterine cavity, something called an endometrial polyp, which is an overgrowth of the normal lining of the tissue of the uterus. Sometimes there can also be scar tissue inside of the uterine cavity. And so we do kind of, wonder what's going on structurally inside of there. And then the last thing that we think about is what's going on with the sperm. Is the sperm of good enough quality and quantity to be able to result in a pregnancy? And so then in practice, what this looks like for a couple who's seeing us for a new infertility evaluation is a careful history and physical exam of the female partner. We'll perform an ultrasound looking for any issues with the ovaries, any issues that we can see with the uterus structurally. We'll check some of that hormone testing to investigate the function of the ovary. We'll also check on your thyroid function, as that can affect the the function of the ovary as well. There is a test called an HSG. Also, sometimes we do a similar test called a saline ultrasound. This is a test where basically fluid is put inside of the uterine cavity that kind of opens up the uterine cavity and lets us look for any of those issues inside of the cavity. And then that fluid also will flow out the fallopian tubes if the fallopian tubes are open, and allow us to visualize those fallopian tubes. And so also gives us information about the fallopian tube function as well. And then we do order a semen analysis for the male partner, which will provide us with information about the sperm quantity and quality.
Just to interject there a little bit, Dr. Cameron. And so we also, as Dr. Cameron mentioned at the beginning, we see couples who are in same-sex relationships who obviously have not been trying for 6 months or a year. They're coming to see us because they desire pregnancy within the relationship, or similarly, women who are coming in who desire pregnancy want to be single parents by choice. And this is the same evaluation that we would do, obviously, except for the semen analysis. And so we want to make sure that all of these compartments that Dr. Cameron mentioned are working optimally before we begin a fertility treatment for that couple.
Exactly. Perfect. For couples who are seeing us for infertility indications, when we do all of this workup, kind of looking for an explanation for why a couple hasn't had success in their attempts thus far, about a third of the time we'll come up with an issue on the female side. Those are sort of the green colored wedges. About a third of the time we'll come up with an issue on the male side. And then actually about a third of the time, we don't have an explanation for why a couple has been having difficulty getting pregnant. And then that's something called unexplained infertility.
So treatment options. So, one of the things, if we find a structural issue, such as fibroids, which are, a mass within the muscle of the uterus, or cysts on the ovaries, these are things that can be corrected surgically. And depending upon the number of these issues, it would dictate the route of surgery or how invasive a procedure is needed. If there's scar tissue within the uterine cavity, as Dr. Cameron alluded to earlier, then we would do a procedure to try to remove that scar tissue to try to make sure that the inside is a good environment for an embryo to implant. Or if there's abnormal tissue growing that could potentially increase the chances of miscarriage, we could try to remove that as well. Sometimes there can be disease around the fallopian tubes. That's called scar tissue. That can be from a number of sources, more commonly conditions like endometriosis or prior infections in the pelvis can lead to scar tissue, and surgery can help to address those. And then if there's a male partner, and if we do a semen analysis that shows there's potentially an issue with count or with how well the sperm are swimming, we would refer them to your urologist for a physical examination, and they could try to identify something called varicoceles, which are dilated veins in the scrotum that can lead to low sperm counts, and those can also be addressed surgically if necessary.
Then in terms of next steps and treatment, so just kind of very generally, our sort of first line treatment, once kind of everything is optimized, if everything looks okay, in the sort of evaluation of those compartments, as Dr. Cross called them, kind of our first line treatment is to do something called ovulation induction with intrauterine insemination. And so the goal of this treatment is twofold. One is the female partner would take an oral medication, so just in the form of a pill, with the goal of, instead of her ovary naturally releasing 1 egg per month for ovulation, the goal would be to actually increase to 2 to 3 eggs per month to just try to statistically increase the chances of pregnancy. And then combining that with what's called an intrauterine insemination, or an IUI. And so this is basically taking a sample of the male partner's sperm, concentrating it, so looking for kind of just the most vigorous swimming sperm, and then placing them directly inside the uterus right at the time of ovulation. That way we know that we have kind of nailed the timing, and also we've given those sperm sort of a shortcut so that they have the shortest distance remaining to swim to meet up with the egg. Alternatively, a more aggressive treatment would be something called in vitro fertilization. This is a therapy where the woman actually gives herself very high levels of hormones through daily injections, the goal being to get as many eggs as possible to grow from the ovaries. Those eggs are then removed through a small surgical procedure and are then combined with a partner's sperm in the laboratory. And a resulting embryo is then transferred back in, can then be transferred back into the woman's uterus to try to achieve a pregnancy. And if there are additional embryos available, they can actually be frozen for future use. So this is a much more aggressive treatment option, but does have some advantages. For instance, doesn't rely on fallopian tubes for the egg and the sperm to meet up, so can be helpful for women who have fallopian tube issues. We also have some options of kind of advanced fertilization technique. So if there is are issues with the sperm that they require some additional help to fertilize the egg, that's something that we can assist with in the laboratory. All right, and I think that's it for our sort of general overview here. And we are very happy to take any questions that anybody has with our remaining time.
The first question is, in cases of infertility, do you recommend testing for men beyond the semen analysis, for example, DNA fragmentation? Oh, that's a great question. So I think it depends upon a little bit of the history. So our initial screening evaluation for the male partner is with a semen analysis. And if that semen analysis is normal, then typically we would not do additional testing unless there's a history of potentially repetitive miscarriages that are otherwise unexplained. Then there may be a role for DNA fragmentation testing. DNA fragmentation testing is quite a controversial area in men's fertility evaluation, as the data has not panned out that diagnosing DNA fragmentation and treating it has improved outcomes in all of the studies that have been out there. But it is something that I do consider for the male partners who are having repetitive miscarriages and or who have an abnormal parameter on their semen analysis called morphology. The sperm all look highly abnormal, then I send them to your urologist for potentially that evaluation. I don't know, Dr. Cameron, is that your practice as well? Or?
Yes, I think that it sums it up. There is, you're exactly right, controversy in our field about the utility of DNA sperm fragmentation testing. Part of that is that most of the studies that have looked at it have kind of all used different ways to test and different thresholds or cutoffs for what's normal and what's abnormal. So it makes it difficult to sort of get a clear sense of what's going on with the data. But Dr. Cross is exactly right. When we have couples where we think there's sort of something additional going on in the male infertility side of things, we will co-manage those patients, certainly with our reproductive urologists, and we appreciate their input. All right, question number 2, do you know how lupus affects fertility? So lupus can affect fertility in a couple of different ways. The sort of number one thing that we think about is that some of the treatments that are used for lupus can impact the ovaries, and in particular can impact what's called ovarian reserve, or the number of eggs remaining in the ovaries. This is primarily treatment with cyclophosphamide, which is common in many women who are undergoing treatment for lupus, and so this is something that we keep in mind. In addition, some women with lupus, sort of depending on the form of lupus and their antibody testing, we know are at increased risk of miscarriage. And so these women we actually treat with additional medications when they become pregnant to try to decrease that risk and prevent that from happening.
So question 3, is it possible to have an HSG clear blockages in the tube? Yes, is the answer to that. So there are certain types of blockages in the tube where there may be like a little bit of a mucus plug where at the connection of the fallopian tube to the uterus. And sometimes we'll find that when we're initially doing your HSG or saline ultrasound that we're having trouble getting that fluid to push through the tubes. And sometimes with additional pressure or maneuvering, we're able to kind of see that tube open. It's hard to say if it was really due to a mucus plug or whether or not there was just a spasm in the tube from cramping. But anecdotally, we have had patients who previously were infertile then get pregnant after their HSG. The data for that is stronger using a certain type of contrast agent that we actually don't use in the United States. But yes, anecdotally, patients have conceived after HSGs, and in some cases, it can help to unblock the tubes. Now, if there's a blockage in the tube that's at the end of the tube, when the tube is fluid filled, then it's highly unlikely that the HSG or saline is going to fix that issue. But yes, I guess theoretically that can happen.
All right, next question. In cases of infertility, does weight play a role? If so, what is the optimal weight? So the answer is yes, weight does play a role in infertility. And there are a few ways through which this happens. Number one, sometimes when women have elevated BMI, this can actually affect the ability of their ovaries to ovulate, to have those sort of nice, normal monthly periods. And we have seen that actually weight reduction can help to restore the ovarian function and bring back that functional ovulation in the ovaries. So that can certainly be a challenge because, as we discussed earlier, if somebody's not having regular periods, then they really do need to see a fertility specialist because there is no way for them, it's very much more difficult for them to get pregnant. So number one, yes, weight can affect the ability of the ovaries to ovulate. However, we do know that even in women who are ovulatory, who are having those regular monthly menses, there are higher rates of infertility associated with women with higher BMIs. And unfortunately, there's also increased risk of miscarriage in women who have higher BMIs. And so the sort of ideal body weight or the goal would be to have the BMI within the normal range, so under 25.
Okay, so my doctor says that breastfeeding can decrease my chances of getting pregnant. How long do you think it will take after stopping breastfeeding for ovulation process to go back to normal? And are chances of getting pregnant going to be higher? Yes, so breastfeeding causes your body to produce a hormone that can prevent ovulation. And so that is the mechanism by which breastfeeding can delay pregnancy. And so most people who are nursing, once they've cut down on the frequency and the volume of nursing, they'll have a drop in that hormone, that prolactin hormone, that will lead to resumption of menses. For some patients, they'll still be menstruating, but they may see some irregularities in their ovulation patterns. Their period won't be completely reliable and predictable, and they may see a shortening of the interval between when they've ovulated to their period. And that's another way that breastfeeding can lead to delays in getting pregnant. But just as another message, breastfeeding is not reliable contraception. You absolutely can still ovulate and get pregnant, so you shouldn't use it as contraception. It's variable from person to person how long it's going to take to resume their normal cycles. But if you've stopped nursing and it's been, over a month and you haven't gotten a period, then you might want to talk to your doctor to see if there's anything that's that's preventing your cycle from coming.
All right, the next question is, if you have had multiple miscarriages between 6 to 9 weeks with no answers or concerns from a fertility specialist, what do you do next? That's a great question. And so there is a set of standardized tests that fertility specialists will do for recurrent pregnancy loss, trying to look to see, can we find an explanation for why this has happened? Because of course it's extremely distressing. The most common cause of early miscarriage is just that the pregnancy, sort of by and large, the most common reason is that the pregnancy did not have the right amount of genetic information in order to go on to create a healthy baby. Unfortunately, our bodies are actually just very inefficient at creating pregnancies that do have the right amount of genetic information to create a healthy baby. And so an early miscarriage is just sort of nature's way of sort of recognizing that and not allowing the pregnancy to develop. However, there can be other causes for recurrent miscarriage. And so there are fertility specialists will order some additional testing looking for issues like thyroid problems, problems with that prolactin hormone that Dr. Cross mentioned, some antibody testing that we know can be associated, and also looking for any sort of structural issues inside of the uterus. About 15 to 20% of the time when we do that testing, we can come up with an explanation for why a woman has had recurrent pregnancy loss, and we can do something about it and treat it. But unfortunately, then in the majority of the times, we don't actually have an explanation or unfortunately have kind of something that we can do to explain and then to fix the reason that these pregnancy losses have happened. The good news is that we know that oftentimes these women will go on to have healthy pregnancies. A lot of patients ask the question, well, can IVF help me in this case? And that's sort of a very nuanced answer. The sort of bottom line is, no, IVF is not helpful for improving sort of overall pregnancy rates, but can be helpful potentially in some circumstances for maybe decreasing the miscarriage rate. So it's hard to answer that kind of generally, and it's definitely worth kind of a one-on-one conversation with your fertility specialist. And those are very difficult situations for sure.
Are there additional tests for women over 40 that have been trying naturally for a while? Can you also speak on PCOS briefly? So the evaluation that we do is the same for patients who are younger who are trying to achieve pregnancy, and women who are so under 35 and over 35. The evaluation is the same, but I think the one point that Dr. Cameron mentioned is that we wouldn't recommend that a person who's over the age of 35 wait longer than 6 months. And if you're over 40, then probably just going straight to a fertility specialist without spending a lot of time trying on your own would be reasonable. That way, we can make sure that there aren't any additional factors outside of age that may be delaying fertility. And most of us would advocate for a couple who's over the age of 40 to jump right into a fertility treatment to try to optimize their chances. And regarding the question about PCOS. So PCOS is a condition that's characterized by irregular menstrual cycles, and in some patients not having any menstrual cycles and no ovulation. And so the treatment for that patient typically includes the oral medications to help increase the chances of ovulation, coupled with either intercourse or intrauterine insemination as a starting point. And then for some patients who have PCOS will ultimately need to undergo IVF. But typically our goals of treatment are to kind of improve the ovulation patterns that may be irregular in that patient group.
And then just one thing that I'll mention for PCOS is that PCOS definitely, as Dr. Cross said, kind of affects ovulation and in that way causes infertility. But if you have PCOS, it's also important to know that PCOS has some sort of long-term health implications, can affect and kind of put you at increased risk for some metabolic things longer term. And so if you are a woman with PCOS, it's also important that that kind of you are seeing a physician who can help you manage some of those longer term issues as well. Which fertility specialists can do. Oftentimes also your primary gynecologist or primary care doctor can do as well. Okay, can you explain IVF in a little more detail? What happens after the period, how many days to take hormones injection? So the sort of the way that I explain to my patients kind of the way that IVF works is that it utilizes our sort of natural biology. So what is interesting is that at the start of each month, Your ovary designates a group or a cohort of eggs to potentially be the egg to respond to hormone and grow and ovulate that month. And typically, your brain only releases enough hormone to grow and mature one of the eggs in that group, and then the others will just die off. The goal of IVF is for a woman to give herself very high levels of hormone through daily injections to try and grow and mature all of the eggs in that group. So practically, what that looks like is a woman giving herself typically 2 to 3 injections per day. Most of these are subcutaneous, meaning they go kind of in your tummy, sometimes in your thigh, 2 to 3 injections per day, typically over approximately a 2 to 3 week time period. IVF is kind of very resource intensive, not just from a financial standpoint, but also from a physical, emotional standpoint. It's a sort of very intensive period. So 2 to 3 injections over a 2 to 3 week period. In the beginning of that 2 to 3 week period, you will be going into the office at a fertility center for ultrasound and lab work monitoring, initially every 3 to 4 days. But then towards the end of that 2 to 3 week period, it's actually typically every other day, and then towards the very end, essentially daily, going in for ultrasound monitoring and lab work monitoring, kind of watching the progress of how your ovaries are responding to those medications. Once we see that the ovaries have responded and that the sizes of the follicles, which are fluid-filled cysts that contain the eggs, are large enough that we think that there should be mature eggs inside, then you take a final injection, which is what's called a trigger shot. And that kind of sets off the hormonal response that lets us know kind of when exactly ovulation will happen. Our goal then is for you to have the eggs removed from your ovaries through a small outpatient surgical procedure, kind of right at the time that they're maximally mature, but before your ovaries have ovulated them on their own. So that's a procedure that's done under sedation. You go home the same day. And then if you are having an embryo transfer, then kind of in that same cycle, then the embryo transfer timeline wise typically occurs 5 days after the egg retrieval. Sometimes people will not have an embryo transfer in that cycle, and then the embryo transfer would be the following month.
So how would treatment differ if the issue is not getting pregnant but staying pregnant? And so the evaluation for recurrent pregnancy loss is different than the infertility evaluation. As Dr. Cameron kind of alluded to, we're looking for known reasons for miscarriage, such as structural issues with the uterus that may predispose to miscarriage, or autoimmune factors that we know can lead to recurrent miscarriages. Similarly, we're looking at genetic reasons that may be causing miscarriages to happen more than what we would think they would occur based on age, by looking at the genetics of the couple themselves to see if they're at higher risk for creating embryos with abnormal chromosome numbers. And so the treatment, if we are able to identify a reason, would focus on the cause. And so that would be uterine surgery if necessary, if there's an issue with the uterus itself, if there is an autoimmune source, treating that autoimmune condition, and if there is a genetic source, meaning that we know that there's abnormal genetics in either the male or female partner, that is a role where IVF may play a role to help try to find embryos that are chromosomally normal. So within IVF, there is an option of doing some genetic testing on the embryos to see which embryos have 46 chromosomes that are arranged normally. And if we are able to identify those embryos that have the correct number of genetic material, 46 chromosomes, we can then transfer only those normal embryos to try to help sustain a pregnancy for longer.
Can an abortion and or miscarriage stop your chances of having a child if you're a patient of IVF and IUI? No. So having had an abortion in the past does not increase your risk of infertility and does not sort of increase your risk of not responding the same way to those treatments. That's a very good question. And I know that, sort of as women, we have a tendency to blame ourselves, right? What have I done to now cause me to have difficulty getting pregnant? And the answer is no. Very rarely there can be complications from the procedure that is used to treat either a miscarriage or for abortion. Very rarely there can be complications from that procedure that can sometimes contribute to infertility. But the sort of bottom line answer is no.
Is there a way to increase your chances of ovulating every month? I guess if medically, yes, there are definitely fertility medications that we can provide that can increase likelihood of ovulation. Naturally, yes, as well. So it depends on the issue. So as Dr. Cameron mentioned, being overweight may increase the likelihood of having irregular ovulation, and so weight loss can improve ovulation patterns in that group of patients. Sometimes there can be issues with insulin resistance and prediabetes. And in that group of patients, getting the diabetes under control with medical treatments like metformin, as well as diet and exercise, can also improve ovulation patterns in a natural way. And that's kind of our mainstays of ways to increasing ovulation.
If thin endometrium is suspected, is there an optimal time in relation to the cycle to have a pelvic ultrasound done to measure thickness? So the lining of the uterus is sort of built up and increases in thickness in response to estrogen. And estrogen is produced by a growing follicle, that sort of fluid-filled sac that has an egg. And so if you were sort of interested in kind of what is the lining of the uterus, during the time of ovulation, the best time to look would be right around the time of ovulation, when there is kind of a large mature follicle that has produced lots of estrogen. That's when the lining will be the thickest right before ovulation, because that's when the estrogen levels will be highest in the middle of the cycle. That said, though, there are studies kind of looking at pregnancy rates with lining thickness, and we know that in the IVF population, so for embryo transfers, the thickness of the lining does matter. But in patients who are getting pregnant kind of themselves, there isn't a sort of a cutoff or a thin lining beyond which we think patients can't get pregnant.
So with multi-year hormonal birth control, do you see the 12-month time frame expanding when a woman gets off it to begin to try? No. So, most patients who are taking birth control will return to their normal ovulatory cycle within a month or two. And so if you're not getting periods after stopping birth control, that's a reason to go seek care from your gynecologist to see what's going on and if there's a reason. Very rarely someone may have a delay in their cycle after stopping birth control, but that is not normal and warrants evaluation.
What are your thoughts on reproductive immunology in cases with unexplained infertility, multiple miscarriages, all miscarriage testing normal, et cetera? Yeah, that's a great question. And I think it's a question that we've all asked ourselves because these are really challenging patient populations. And it's really difficult to say to patients, we don't have an explanation. We don't have anything that the data supports that we try. And so there have been, several studies and case series trying to look at use of immunosuppressants in these populations. And unfortunately, none of the studies have shown clear benefits. And so we don't routinely recommend these therapies until we have some evidence that the data supports their use.
I was on combination birth controls for several years and would skip the placebo pills for several months at a time. Would that have any impact on my eggs? No. So, the the supply of your eggs, as I mentioned before, goes down over time, no matter what you're doing, whether or not you're ovulating or not, birth control or not, pregnant, nursing, etc. That process goes on, unfortunately, and that egg supply does go down. So no, you skipping the placebo pills would only lead to you not having a shedding of your uterine lining. It doesn't have any impact on your ovaries or on your egg supply.
Okay, final question. Can vitamin D insufficiency cause infertility, miscarriage, etc.? That's a great question. And there's actually a lot of kind of new research coming out on this topic right now. And we do think actually that low vitamin D levels may be associated with increased risk of miscarriage and with some potential increased risk of infertility or time to pregnancy. So that's a great question. I actually didn't have that on my preconception screen slide, but that is something that we are checking as well now. And we do recommend trying to have vitamin D levels in normal in women who are about to become pregnant. This can be either through just kind of over-the-counter supplementation, but also just maintaining that healthy, balanced diet oftentimes is all that you need to have adequate vitamin D levels.
All right, thank you. I think that is all our questions for today. Thanks everyone for joining, and a link of the program, the recording, will be sent to everyone who registered today.
Thank you so much for having us. It was our pleasure to be here for you guys.
Yep. Have a great day.